Me okay. My name is Stacy Lindau. I'm a professor and physician scientist here at the University of Chicago. I'm appointed in two departments. I'm a board certified OBGYN. I'm also appointed in the Department of Medicine, Geriatrics. And I've run a clinical practice now for more than 10 years where I specifically focus on helping women recover sexual function after cancer treatment and in the context of other common and complex illnesses. I think I'm supposed to be looking at this camera. Is that right? I'm not sure where to look because the camera's there and you're all up there. But
general direction is
okay, all right. Well, I'm so happy to be here. Thank you so much for inviting me.
So happy you're here.
And if you want me to use the mouse to advance,
or you can use the keyboard.
Okay.
You'll just use the little arrow key.
Got it. Okay.
Oh, here we probably click
there. I can hold on to the mouse, and you can hold on, and there we go. The arrow should work.
There we go.
There you go.
Okay.
Perfect.
So we have, I think our goal is to maybe, for the didactic portion, maybe 20 or 25 minutes. And female sexual function, as you can imagine, is a broad topic in health and healthcare. It was too much to tackle for a brief intervention here, but I am going to focus today on understanding dyspareunia in otherwise healthy women. So dyspareunia is one subtype of several types of sexual dysfunction, which you'll see today. You see the disclosure statement. And our learning objectives are to integrate an understanding of female dyspareunia into primary care practice, to effectively communicate with women about dyspareunia, and apply knowledge to effective frontline treatment of dyspareunia. In addition to clinical practice and our research activities here at the University of Chicago, we've developed a web-based platform called Woman Lab. This has been developed with support of initially from the Jewish Women's Foundation of Metropolitan Chicago, private donors, the Women's Board at the University of Chicago. And our goal is to share everything we know about female sexuality in the context of aging and disease like cancer and other conditions. We've been working on this for about 2 years. It launched just about 18 months ago. Woman Lab is free to the public for anybody who has an internet connection, and we've reached about 46,000 people in 184 countries with this platform. It is designed to meet the needs of women, and we have an advisory board of a diverse group of women who have advised on all aspects of the content. It's also designed to serve the needs of healthcare professionals. So it's for, we say, for all women and everyone who loves and cares for women. So I'm going to point to tools that are on this public-facing resource throughout my talk that I hope will be helpful for you in as patient education materials or for yourselves. Okay. First of all, how do we talk about sex in the routine clinical encounters? And I, by the way, I would ask that you, when we're thinking about women, we're thinking about women across the life course. I've been studying sexuality and aging for more than 20 years. We published the first ever comprehensive study of sexuality and aging in the New England Journal of Medicine, 2007. Sort of surprising that that was the first study in 2007. But the fact is, evidence repeatedly shows that women across the life course, women of all ages, life stages, health conditions, value their sexual function, even if they don't have a partner, if they feel it's part of their health, part of their identity. They think it's appropriate to discuss sexual function issues in the healthcare setting, but they want the healthcare professional, and most of the studies have asked about the doctor specifically, but they want the healthcare professional to raise the topic. So how do we address the question? Well, one idea is just to routinely include an item on the review of systems or an entry checklist that asks, are you having a problem or a concern with respect to your sexual functioning? And here you see a clinical screener that was developed by Catherine Flynn and other authors, including myself, using very rigorous psychometric science to establish an effective and efficient way to screen for sexual function problems in the population. So this is published in the Journal of General Internal Medicine. This checklist can work for men and women, as you can see, and it quickly helps you hone in on what problems a person's having. What are the sexual dysfunctions? Well, the DSM-5 revised the definitions of sexual dysfunction, in some ways consolidating diagnoses or conditions that had been separate. But what we're working with today are three main disorders: genital pelvic pain penetration disorder, The Latin for that term is dyspareunia, and that is defined as penetration difficulty, anxiety, or fear about penetration. Interest or arousal disorder, this is an example again where what had been two separate conditions has been consolidated: reduced interest, excitement, genital sensations, and orgasm disorder, delay, absence, infrequent, or decreased intensity. To meet DSM-5 criteria, these conditions need to persist for at least 6 months. They occur in 75 or 100% or more of the time, or in the case of GPPD, really it's GPPD, these symptoms need to be persistent or recurring. They occur with clinically significant distress for the woman herself. It's no longer acceptable to diagnose a woman with a sexual dysfunction that is causing distress solely for her partner, although in earlier iterations of the DSM that was permissible. So a woman could be diagnosed with dysfunction based on partner's distress, and the condition occurs independently of relation to distress, other medical condition, non-sexual mental disorder. Now, most of you, unless you're practicing in psychiatry, you're not bound to these DSM-5 criteria to make a diagnosis. And in fact, for us, for primary care professionals seeing women for medical conditions, most people do present with a co-occurring relationship distress that may precede the problem or may result as a consequence of the problem. They have medical conditions. That doesn't mean they don't have a legitimate sexual problem. And fortunately in the ICD-10 codes, there are plenty of codes you can use. Dyspareunia is one of them to indicate a problem that you're managing. So I think it's really more for academic purposes to understand these technical definitions, but in clinical practice, it's still legitimate to use the problem's dyspareunia, even if the person has a co-occurring relationship issue. I'm happy to answer questions about that if it's not entirely clear. So I love etymology, and here you see the etymology of the term dyspareunia, difficult, or painful, and parunos, lying with. So difficult lying together is, and I teach my patients that that's what this term means. Here you see a picture that illustrates the layers of the genitopelvic floor. So you see the muscle layers. We peeled back here the skin, the subcutaneous fat. You see the muscle layers, and you see the key organs. I use a map of the genital anatomy when I examine my patients. It actually has the layers at that point. It doesn't show the layers peeled back. But I do think it's important to come to an understanding with your patient, a shared understanding of this anatomy. So believe it or not all women know the term clitoris, and they don't know necessarily where is the clitoris. The clitoral gland is hidden or protected by the clitoral hood, and unless you've really looked down there, it might not be totally clear. So there's the clitoris, the urethra, the vagina, the anus, and I explain to people where these structures are in relation to one another. I use a hand mirror and a map for my physical exams. I never force it on somebody. A person isn't comfortable or doesn't want to do it. Of course, I don't require that, but I do really think there's value in using the physical examination as an educational opportunity. So dyspareunia, recurrent or persistent pain associated with attempted or complete vaginal entry or penile vaginal intercourse. And vaginal entry, of course, could be with a finger, it could be with a dildo or vibrator. We have to, I think I would recommend caution. We shouldn't assume that people presenting with this condition have a male partner. In fact, in my clinic in the last 2 weeks, a third of my patients have been women with female partners presenting with dyspareunia. So there are two ways to differentiate, sort of two ways to classify dyspareunia, and this I think is the simplest. Let's just think about superficial dyspareunia or dyspareunia with early penetration and deep dyspareunia. It's certainly possible that people have both, and we can talk about when that occurs. The vast majority of cases of dyspareunia are superficial dyspareunia. It's pain with genital contact, it's pain with early penetration, and it oftentimes relates to hypertonicity in the pelvic floor. Deep dyspareunia is, I would say, fewer than 10%, maybe fewer than 5% of the patients I see present with deep dyspareunia. Now, I have a specialized practice, remember, that's treating sexual disorders in women with cancer and other conditions, and so it's not a representative sample of all women who show up with dyspareunia, but still deep dyspareunia is much less common than superficial. And deep dyspareunia should be a red flag. These are the patients who are, especially in the absence of any history, like they haven't had a recent hysterectomy where they might have some granulation tissue at the apex of the vagina. A new complaint of deep dyspareunia is one that warrants some serious attention. Be concerned about the possibility of a neoplasm affecting the cervix, the uterus, the ovaries, the fallopian tubes, or deep in the pelvis, and use a higher level of skepticism about the possibility of a more serious condition. It's not to say superficial dyspareunia is not a serious condition, but it's unlikely to be caused by a neoplasm, for example. Let's talk about vaginismus. There's been some recent discussion about retiring this term and debate about the value of the term. I think the problem is the term gets misused. So I still use it, but I want to encourage you to use it for a very specific situation. It has been used to imply sort of uptight female can't have penetration. It's been used to imply type A personality or anal retentive. It has been used in ways that sometimes women come with complaints of sexual function concerns. They've heard this term and they don't like it. And I think it's, like I said, it's because it gets used not quite correctly and not constructively. So I think a way to use it constructively is to understand it and explain to patients what it means. And essentially, physical therapists will say isthmus means spasm, and that's been part of the controversy. Is there really spasm of muscles, or is it just hypertonicity of muscles or hyperreactivity of muscles? But for today, I'm going to talk about vaginismus as it relates very specifically to the muscle that you see labeled here, the bulbocavernosus muscle. So the bulbocavernosus muscle is essentially a sphincter muscle, just like the anal sphincter. And when you look at the picture, you see really two sphincter muscles, or two muscles that have this circumferential location around two different openings, one around the anus, one around the vagina. The bulbocavernosus muscle connects to the anal sphincter muscle, and it can become hypertrophic. In the resting state, it's slightly closed. It needs to become aroused, or there needs to be another maneuver in order to release the muscle open. And when women have pain, the muscle does become reactive. It will be hyperreflexive. Even a gentle touch, or a touch with a Q-tip, or approaching the vulva with a speculum, can cause that muscle to tighten up even further. And vaginismus, in my definition, is a hypertonicity, usually a thickening, a reflexivity of this bulbocavernosus muscle. Women will, if a woman says, I'm having painful intercourse, and you ask, well, where is the pain? Is it near the opening, or is it deeper inside? Most will say it's near the opening, it's with penetration. And then they'll say things like, it feels like he's hitting a wall. It feels like I'm scarred shut. It feels like I'm a virgin again. And you see the fingers in the photograph there. It's not uncommon that patients will say it's this far in. They'll say, I have trouble getting a tampon in. I can't get it past this far. Well, what's this far? This is the thickness of, that muscle is a 3D muscle. When it is tight, when it's hypertrophic, it's about that thick. So these are pathognomonic symptoms or complaints, if you will, from a woman who has vaginismus. Now, I see women with cancer, even if you see women who've had cervical dysplasia, when a woman develops a problem like this that she's never had before, her first thought could be, there's a tumor in my vagina. And it's not uncommon that my patients will admit that concern. Their partners are worried about that too. Like, wait a minute, all of a sudden there's something there. I can't get in. And to walk around with a muscle problem that's easily correctable, but worrying that it's cancer or a congenital deformity is just, that's real suffering that is preventable. So what are some common causes of vaginismus in the otherwise healthy women? Well, vaginal dryness is a common problem. In younger women, combined hormonal contraceptives can contribute to vaginal dryness. It seems counterintuitive. I can explain more why that is. Certainly menopause can contribute to vaginal dryness, and hyperhygiene is a very common problem that contributes to vulvar dermatitis, dryness, irritation, itching that gets misunderstood as yeast, treated with antifungals, which doesn't make the problem better. These are the most common causes. A history of genital trauma or disease also can contribute to vaginismus. So I call the sedentary lifestyle that we're increasingly living as commuter and computer syndrome. If you ask your patients with new onset dyspareunia how many hours a day they sit, so oftentimes around here there's students, they're sitting 8, 10, 12 hours a day working on their dissertations or their laboratory experiments. They do walk on campus, but then there are people who are largely doing computer work like and have a half hour, an hour commute to work. Sitting on the vulva is a contributor to this problem. Straddle and coccyx bones injuries, like a balance beam injury, biking, ice skating injury, these can be old injuries that nobody ever thought about. The coccyx bone can scar, can bruise. They can get some tethering from the coccyx bone and the muscles that connect to it. That can be a contributing factor. Recurrent vaginitis, HPV, certainly cancer, factors that draw attention to the vulvovaginal area, that draw worry to the vulvovaginal area also can contribute. Mood and cognitive issues are also, they can be contributing factors. They can predispose to vaginismus. They can also be consequential to vaginismus. It's very frustrating and annoying and worrisome, especially with a new onset problem. Like, I've been able to have sex, no problem, no problem, no problem. All of a sudden there's a wall there, you can't get in, it's painful, and these can trigger negative affect or mood problems. And people oftentimes feel ashamed and they feel guilty because they can't meet their partner's needs. Relational issues, stress in the relationship, stress at work, anything that causes overall muscle tension. Some people just hold their tension in this part of their body. So if you have neck tension, you have low back tension, you can understand why you might have tension in some of the other muscle groups. A history of trauma or abuse, including sexual abuse, but not only sexual abuse, does predispose to sexual function in general. Having said that, it is very important to not have a knee-jerk response to a woman who presents with a sexual function concern that goes straight to a trauma or abuse history. I've even seen patients who have said to me, you know, I never thought I was abused, but my doctor really pushed me to think back to whether I might have been abused as the cause of my problem. She'd gone to her mother, to her sisters, looking for a cause, you know, looking for an explanation for the problem. And there was no evidence for abuse, but she was really traumatized by the suggestion that the main cause of this problem might have been abuse that she had forgotten about. Now, having said that, 20 to 30% of women identify a history of sexual abuse or assault in their lifetime. It is a common problem, but it's still the case that the vast majority of people who present with sexual function problems do not have a history of trauma or abuse. And we just have to be careful not to over-connect those ideas in talking with our patients. So here are some resources for you and for your patients on the Woman Lab website. I've written a couple pieces here to tell the story that I tell, you know, one-on-one in the clinic, just to try to scale up the reach of what we know. Your vagina has a sphincter, helping people understand this bulbocavernosus muscle, how to find your bulbocavernosus muscle, explaining what is vaginal dilation or stretching of that muscle, and tools to help women find pelvic floor physical therapists, which can be a very useful adjunct to treatment of this problem. Now, if you're going to do frontline treatment, so you've examined the patient, she's had those pathognomonic symptoms, you don't see any skin problems or other explanations near or just past the introitus for this pain, you might think about how to treat the patient. And one possibility is to use what's called vaginal dilators. Now, patients don't understand why these are called dilators. They especially don't quite understand why there are tiny, tiny ones. I think it's important to explain that these were developed primarily for people who develop stenosis or scarring in the vagina as a result of radiation therapy, and have been extended for use to treat a musculoskeletal problem or a muscle problem, mainly that is vaginismus. So they come in some people look at the very small sizes and they feel like, oh, that looks like a small boy's penis size, like that's very strange. So it does need some context when you're introducing the dilators and helping people understand why sometimes some women need to start very, very small. There's also a congenital anomaly of absence of the vagina, Rokitansky, Kuster-Hauser syndrome, Meyer-Rokitansky-Kuster-Hauser syndrome, very rare to see in practice, but that would be another condition where a neovagina can be created or sustained using vaginal dilator therapy. Pelvic floor physical therapy is also a very useful adjunct if it's available to your patients. There's no evidence to recommend one dilator type over another. Here you see a rigid plastic or a nylon dilator all the way to the right. For some reason, radiation oncologists tend to hand these out. The silicone dilators, you see two different sets in the middle and on the left. They just are more lifelike, they're more flexible, and therefore I think they're more sort of physiologically relevant to treating vaginismus than the very rigid nylon types. And these are available over the counter. The ones on the left is a prescription distribution, and the Pure Romance, for example, just one of several types, are available direct to consumer. The evidence on how to use the dilators, when to use the dilators, how long you need to use the dilators is pretty slim. And I just cite two Cochrane reviews here that give you the summary on the evidence. Nonetheless, based on expert opinion, there is value in helping women understand how to work with that bulbocavernosus muscle, how to release it, and I don't know of evidence to suggest there's something better than the dilators. Some practitioners will suggest for women who maybe can't afford a dilator, using a tampon inside a condom, using a candle inside a condom. I think being creative to help women of low means is important, and safety is also important. Condoms can be difficult to insert when there's a lot of tightness and dryness. Eliminating hyperhygiene. I don't know how frequently you speak with your patients about how they wash in the genital area, but the bottom line is there is no need for soaps between the labia or in the vagina. I explain to my patients the vulvar mucosa and the vaginal mucosa are like the eyeballs and the nose, and we don't put soaps. We don't scrub on those organs. They clean themselves. So starting early with young women to help them understand how their bodies work, and recommending against pads, wipes, douches for sure, soaps directly to the vaginal area is very helpful. And sometimes that's just the problem. There's just hyperhygiene and we need to eliminate it. It takes time, but things will recover. Some women need moisturizers and lubricants to help with vaginal penetration. So now think a menopausal woman, maybe think a woman who's on an anti-estrogen therapy or has had a hormone-dependent tumor and can't use estrogen. Estrogen is FDA approved to treat dryness and pain related to sex resulting from menopausal dryness, but not all women want or can use those products. Moisturizers and lubricants are available over the counter. There are literally hundreds of products out on the market. The FDA treats these products like medical devices. In the past, they've been treated like cosmetics. Even though these products go in the vagina, which communicates with the cervix and then with the peritoneal cavity, they are not subjected to really any rigorous evaluation. That's problematic. There needs to be a policy remedy for that, and I've been an advocate on that front. We're not there yet. So my bias is to use products that have the fewest ingredients, the most ingredients that the woman has heard of before and can pronounce. I try to avoid products that have known irritants like parabens and glycerins. And a couple other tips here. Moisturizers are meant to be used for maintenance on a regular basis to increase hydration. There are a variety of products out there, not great evidence to say one is better than another. Hyaluronic acid based products are effective. There's a little bit of research on them. They have minimal ingredients, and very few patients complain of irritation with those. So we've written a blog on that particular product type. Lubricants are meant to reduce friction, and there are three main classes of lubricants. We've published a handout on the various lubricant types for counseling purposes. Water-based lubricants are what we use for a speculum exam. Why do we use those? Because they come in a bacteriostatic form. We need to use that for examining pregnant women, but women leave the office thinking water-based lubricants must be the best lubricants because that's what the doctor or the nurse practitioner uses. Well, they're good if you want to increase friction. Because they're primarily water, they evaporate very quickly, just like saliva does. Saliva is not a great lubricant, and things get sticky and tacky. So some people are looking to increase friction for pleasure after, say, multiple childbirths, go for a water-based lubricant. They also tend to have preservatives, glycerins, parabens. The silicone-based lubricants are silicone-based. They also have those preservatives. They never dry out. They're very, very slippery. That's an alternative to the water-based. I prefer the oil-based lubricants. They're not compatible with condoms. They can break down a condom, but you can use food-grade oils like coconut oil or olive oil, and those also work if oral sex is part of the repertoire, and for many people, oral sex is part of the repertoire. It would be too much to try to cover all therapies for vulvovaginal atrophy. Let me just start by saying, if you have a young woman who's been on a combined hormonal contraceptive and she's developing vaginal dryness after even a year of being on the contraceptive, but oftentimes it's after 2 or 3 years, before you add estrogen cream to her vulva, please talk to her about alternative methods of contraception. We don't have a full understanding of why some women seem to be hypermetabolizers of these drugs, but what happens is the drug is metabolized in the liver, there's an increase in sex hormone binding globulin, and what happens, you're taking exogenous estrogen, but you develop dryness because you're producing so much sex hormone binding globulin, you're binding up all your free estrogen. So if we don't understand this, our tendency is then to give people a birth control pill with more estrogen, and it actually does the exact opposite of what we want. It even further upregulates the sex hormone binding globulin production and deprives the end organs of their estrogen. So a young woman with menopause type symptoms on a birth control pill should have a conversation about an alternative treatment. Women who have had their ovaries removed or who are chemical or surgical castration, if you will, are menopausal and may or may not be eligible for hormone therapy. But here you see, and I'm sure you're familiar with some of these therapies for atrophy, and the slides will allow you to look in more detail, but I've tried to summarize for you what are the major formulations and compositions. You may not be familiar yet with the vaginal estrogen suppository. Believe it or not, there had not been a vaginal estrogen suppository on the market. But when the DHEA suppository came out, there was motivation by the pharmaceutical industry to compete with DHEA. So this vaginal estrogen suppository is out. I've not heard yet that anyone's insurance company is covering that particular formulation. But I think the more options, the better. So I'm not adverse to it. Other vaginal therapies, DHEA, evidence is limited on benefit. It's a little questionable why it's helpful, because really what happens is DHEA inserted in the vagina converts to estrogen. So it's not really an alternative for women who can't use estrogen-based products. Lidocaine, there has been studies about using lidocaine around the vaginal introitus in order to eliminate or decrease pain. It does have its role. It's not for every situation, and certainly if a woman has vulvar dermatitis because of hyperhygiene, putting lidocaine there could really burn. The gel is alcohol-based, and that's why I list the ointment here in terms of how it feels when it goes on. And I would urge caution around recommending the vaginal CO2 laser. There are a growing number of healthcare professionals who are offering this product. It costs them somewhere between $150,000 and $250,000 to purchase the machine. And then, as you can imagine, there's a high degree of motivation to do enough procedures to pay back for the cost of the machine, but the evidence is just not there in my view. And that recently the FDA backed me up in my skepticism with a warning against the use of these energy-based devices for vaginal rejuvenation or vaginal hydration. The physical examination is critical. Any patient, any woman who presents with sexual function concerns should have a physical examination by somebody who knows how to do a gynecologic exam. That is a golden rule. We've written a whole team of professionals, interdisciplinary group of professionals working in the field has written detailed instructions on how to perform a physical examination of a patient who presents with sexual concerns. This was written for women who present with cancer, but it's very relevant to the general population, and I hope that would be a useful resource for you. What are the exceptions to the rule? Adolescent patients typically do not need an internal gynecologic exam, although if they've been sexually active, that may be warranted. A person who cannot tolerate the exam when she presents for sexual dysfunction concerns, we may need to address some of her concerns before we can build the trust to do the exam. And a person seeking help to have pain-free or pleasurable sexual intercourse near the end of her life. Say, in my case, I've had stage 4 breast cancer patients who still want to be intimate with their partners. There's really no need for a physical exam at that point. We just do whatever we can to palliate or to enable the sexual encounter. I will I want to make sure that you have a slide on trauma-informed care. The principles of trauma-informed care are useful for caring for women in general. I don't think we have to establish that a woman's had a history of trauma in order to treat her in a respectful and non-traumatizing way with the exam itself. There's good evidence about how to do this, and I use these strategies in my examination of virtually all of my patients. And here are a couple of resources for you or for your patients that I've referred to during the conversation. What to do for vaginal hygiene and what not to do, how to find your bulbar cavernosus muscles, education piece about lubricants and moisturizers. We date all of these tools, and our intention is to continue to keep them updated. We also welcome feedback, requests, or you think something could be better, please share that information with us. Thank you so much for the opportunity to share this knowledge with you today, and I'm happy to take questions.
Excellent, thank you. Does anybody have any questions for Dr. Lindau? I had a question.